Okay, thank you. Right. Good evening, everybody. Welcome back again to another edition of the Dr. Diva Patil Postgraduate Lecture Series. We've been conducting these since 2015, and we've been having it done very regularly every month. And we have invited various people from various forums to come and discourse at our platform. And we are very happy to have back with us Dr. Avinash Desouza, who has shared his wisdom with us on various occasions in the past as well. And today he is back with another interesting topic. And to chair the session today, we have with us Dr. Prasad Deshpande. I've known him for many years, and he is a very, very soft-spoken, gentle human being, an astute and wise person nonetheless. But his modesty definitely is his USP, and he's currently working as a professor of psychiatry at the Government Medical College at Aurangabad, which is now Chhatrapati Sambhaji Nagar. He says he's a government servant, though I suspect he's a lot more than just that. He is a undergraduate and postgraduate medical education student from Mumbai, and now he is working at Aurangabad. And in his own words, he's just learning to be just be. Welcome to the platform, Dr. Deshpande, and I thank you very much for making the time and being with us today to share this very, very interesting discourse. And I now hand over the proceedings to you to introduce Dr. Avinash D'Souza and take the session forward. And I shall come back at the end to just wind it up. Over to you, Dr. Deshpande.
Thank you, Dr. Rashmin. Good evening to all of you present here. I am feeling joyful to be a part of this session, suicide types and clinical assessments. We are going to listen from Dr. Avinash D'Souza, and I feel equally happy to share about his academic achievements and his academic standing today with all of us present here. Dr. Avinash D'Souza is a consultant psychiatrist and a psychotherapist. He is a consultant school psychiatrist also, and he can be found at Santa Cruz West in Mumbai. He's a research associate at the Department of Psychiatry at Lokmanya Tilak Municipal Medical College in Sion Hospital, Mumbai. This is the same place where I got opportunity to do post-graduation. He is a founder trustee of Desouza Foundation, a trust that works in the area of mental health awareness across all sectors. He also happens to be an associate professor and secretary of the International Institute of Organizational Psychological Medicine. It's an organization that works in the field of organizational psychological medicine across 7 countries. He's also an international faculty for UNESCO chair in bioethics, and he works overseas with around 8 countries. He is a chief editor of 2 journals, namely the Indian Journal of Mental Health and Annals of Indian Psychiatry. He is also an associate editor of 3 journals, namely Industrial Psychiatry Journal, Global Bioethics Inquiry, and Indian Journal of Psychiatry. He works with 8 mainstream and special schools in Mumbai as a visiting school psychiatrist, a counselor, and a school mental health expert. He is a visiting faculty and professor at various teacher training courses across Mumbai and at multiple and psychotherapy training programs across India. He has over 750 publications in international and national journals, and he is the author of 12 books in the area of mental health. He's one of those few psychiatrists who, in addition to a psychiatry degree, has a master's in counseling and psychotherapy. He's an MPhil in applied psychology, an MBA in human resource development. He has been awarded a doctorate in clinical psychology from University of Hertfordshire, UK in the year 2011. So, looking at the depth of the info from Dr. Avinash D'Souza's academic life, I now welcome him to start and deliberate today on the topic suicide types and clinical assessment.
और मेरा स्क्रीन शेयर इधर आना चाहिए. Is my screen visible?
Yes, Dr.
Yes, it is.
Avinash.
Yes. Okay. तो मुझे स्क्रीन डालना है. Okay, good evening, everyone. And the reason I chose this topic is because it's a topic which is very close to my heart, and I feel every suicide is preventable. But more importantly, I felt at a postgraduate level, it's very essential for students to understand suicide from a types perspective and a clinical assessment perspective. It's going to be a very clinical presentation, and with some points on how to help you navigate these issues, as well as I've kept it very basic and theoretical, because I feel basic aspects about it are very often not covered. So if you look at what is suicide, basically people look at it as an act or an instance of taking one's own life, either voluntarily or intentionally, especially by a person of years of discretion and of sound mind. Now, the other people also say it's the action of killing oneself intentionally or the action of taking one's own life. This is what are the dictionary meanings. We have always felt that suicide is associated with a psychological problem. In most cases, yes. In most cases, there may also be a sociological stressor. So there'll always be some stress that is leading to it. No one would want to just end their life for no reason. This is something which Emil Durkheim said, and it's something which is very, very important, I think, from a clinical perspective, that each victim of suicide gives his act a personal stamp. So we can't compare two suicides. This expresses the person's temperament, the special conditions in which he is involved, and this consequently cannot be explained by the social and general causes of the phenomenon. So what may worry one person, and one person may manage, for example, financial stress, one person may manage it very well, and the other person may very often succumb to it. Can you unmute those who are here? So sometimes it can happen that one person may have financial stress and uh, overcome it, and you have another person who may have other issues, financial stress, and try to end his life. So each victim of suicide gives a personal stamp. So what are the types of suicide? I'm going to look at types and clinical assessment interchangeably, because the lecture is going to be more from a clinical flow. So if you look at Emil Durkheim, who was one of the main early researchers of suicide, he spoke about different types of suicides based on the different types of relationships between the actor, that is a person committing suicide, and his society. The one was something known as an egoistic suicide. So according to Durkheim, he said when a man becomes socially isolated, or he feels that there's no place in society for himself, he destroys himself. This is the suicide very often of a self centered person who may lack altruistic feelings and is usually cut off from the mainstream of society. So, very often we see people who suffer silently, and they sort of do not really mix with others. They later sort of succumb to suicide, and which is known as an egoistic suicide. The second type is what is called an altruistic suicide, which is a type of suicide that occurs in individuals where this is the it's done more for the greater good of mankind. It's done more for the over integration of the individual into the social milieu. So for example, sometimes it could be somebody who gives up their life for in a freedom struggle, harakiri, which was done by Japanese people. Hindu wives might have a suicide ritual sometimes, which is cultural. So these are what are called altruistic suicides, done for the greater good of others, and it's done when individuals are very close and uh, intimate. The third type of suicide is something called anomic suicide, and this type of suicide is due to a certain breakdown of social equilibrium. So very often this can happen when there may be suicide after bankruptcy, after you win a lottery. It could be due to a failed love affair. It could be due to multiple other things. Anomic suicide takes place in a situation which has cropped up suddenly. You also have something called fatalistic suicide, and fatalistic suicide is a type of suicide which is due to over-regulation in society. So when a servant or a slave commits suicide, or somebody who has not been able to deliver a child commits suicide, the word barren woman here written is because that's how Durkheim described it. This is an example of fatalistic suicide, and it's due to over. So he gave us these four types of suicide: egoistic, altruistic, anomic, and fatalistic. It's very important to understand as we go further that there's another type of suicide which is known as copycat suicide. So very often when we have uh, somebody that is famous, and so it's named after a German novel, particularly wherein they feel the Werther effect is an effect where you see a spike in suicide rates which are committed in a similar way. So, for example, in the 5 months following the news of Robin Williams' death, who was a very famous actor, studies say that there was a 10% increase in suicides. Even more significant was that there was a 32.3% spike in suicides by hanging, which was the same method that Williams used. This likely affects people who are already contemplating suicide. So if I'm already suicidal and something like this happens, it may not increase the amount of suicides in the long run, but it simply encourages a clustering of suicides from happening. And what happens is that people commit suicide in the same way. Therefore, it's known as a copycat suicide. And the Werther effect is the effect which is termed as to when media sort of speaks a lot about this suicide, then we see what is known as the Werther effect. Coming to the concept of anomie, which is very important for suicide, and it's very important that anomie in individuals and society is a condition of instability and disintegration. This stems from the background of previously shared norms and values. So, what are examples of anomie? People say living in high rise residencies, they feel disconnected from one another and they struggle for loneliness. People engage in organized theft because they do not have other ways to accumulate wealth. Individuals may resort to criminal activities during times of war. So, anomie is when there's instability and disintegration of society. And the causes of anomie is because there's a breakdown of social norms, and there may also be a loss of one's sense of social belonging. It's a common question asked in your Viva. Sometimes you could get types of suicides as a short note. So anomie is normlessness, as we described. If an individual or a group go against socially acceptable behavior, it's an anomic situation. It's important to understand that suicide can also occur due to something called alienation. And alienation is where there is less integration among people in a community. When we say less integration, they do not meet, they do not speak, and they do not feel connected to each other. There is also something known as a suicide pact. A suicide pact is when two people in a relationship, most probably a romantic relationship, sometimes even family members, particularly when they're going through stress, they decide to all end their lives together because they feel they can no longer face society the way it is. And this is what is referred to as a suicide pact. So this is something which is very important. So suicide pacts can happen, like we see romantic couples who are not allowed to meet may try to end their lives. So this is what is referred to as a suicide pact per se. It's very, very important that media also reports suicide in a responsible manner. And the reason for this is that very often ghastly descriptions of the procedure, multiple photographs of what happened. Multiple aspects can lead to an increase in suicide. So media reporting of suicides is very important, and I think uh, from the Indian perspective, we've had some researchers, including Dr. Devavrat, who has done research on media reporting and how newspaper reports, etc. So that's also something which is there. Now, what's very important is that we do not use images when reporting suicides in media. So photographs or video footage of the scene of suicide shouldn't be there. The person or the family from the scene of suicide shouldn't be there. Suicide notes, final text messages, social medias, or email posts from the deceased should not be there. One should not have insensitive representational images like picture of a noose or a person standing on a ledge, etc., to depict, because this can encourage others to go in that direction. So if you look at another form of suicide that we see in India, which I think farmer suicide has been very often asked as a short note in many exams recently, comes up because I think the farmer suicide is one wherein there is loneliness. There's no sense of enemy per se, but it's done more because there are financial pressures. So as if you can see, just give me 1 minute. Yes, how are you, Andy? Yeah, how are you? Yes, yes, tell me. Hello? Yes. Can you hear me now? Can you hear me?
I request listeners to make their own questions, because at the end we are going to have a question answer also with our speaker.
Am I audible?
Yes.
Yes. Sorry, my son is on a trip and he called. I'm very sorry. Yeah. Yeah. Anyway, so coming to a very important aspect of suicide is farmer suicide, which is very often one due to financial pressure. And as you can see, I've just put this because I think you should be aware a little about this, that around a lot of suicides have happened. If you can look at it, 5,000 plus. There are some states where there are zero suicides of farmers, and they are Bihar, Bengal, etc. But Maharashtra has been one at the forefront. We've had a lot of psychiatrists who've been doing work in this area. The number of suicides have reduced, though they've not reduced drastically, but it's something that I think you should know. And as you can see, Maharashtra tops the list, but otherwise, we have Karnataka and Maharashtra the highest. So this is sometimes a short note in your exam. So I've just put these statistics here. We also have something known as mass suicide. So mass suicides are when a group of people who are religious may all want to end their lives together, and mass deaths occur. So this is 39, 40, 50, 100 people trying to end their lives together. So this happens particularly in, it happens in religious cults. It happens in certain ashrams. It's certain in certain ashrams, and that is what is referred to as the mass suicide. Now, someone also, amongst the classifications of suicide, someone even spoke of a cultural kind of suicide, which is referred to as sati or jawhar. We don't see it anymore, but it was there in the olden cultures, where the lady would end her life by entering the funeral pyre of her husband. Now, if you look at statistics in India, uh, suicide rates are on the rise. There is no doubt. The rates of average, we have around 12 suicides per 1 lakh population, so that's on the rise. If you look at certain states, particularly like Chhattisgarh, Telangana, Tamil Nadu, and Sikkim, and Sikkim has the highest suicide rate of 39.2 per lakh. So that means it's something which is very, very alarming, and we need to look at. Tamil Nadu, Chhattisgarh, and Telangana state are in the 20s. But if you can see, luckily, otherwise, the other states, we do have Karnataka and Maharashtra at a high, even Kerala for that matter has a high suicide rate. And Andaman and Nicobar, 39.7. So that's higher than even Sikkim. So I think there's a special cultural angle that one may need to look into those areas and try and see what's happened. In the pandemic year also, we've seen a lot of, so pandemic suicide, post pandemic suicide also has been a question that's very often asked in the exam. So the NCRB data has shown a huge jump in suicides among students. So 21.2% increase in students suicides. Also salaried professionals, a lot of them try to end their lives. A lot of daily wage earners suffered during COVID. Retired people became lonely, unemployed people suffered. So all this has happened in the COVID pandemic. Now, whenever you get a patient with suicidality, it's very, very important to understand that there are different terms that we use. One is suicide attempt, that is the attempt to kill oneself, where you make a plan or you may act impulsively. So you ask the patient whether there's a specific plan or intent. How strong does the patient feel that he wants to end his life? Whether there's actually a plan, how, when, where, it's very important. And whether there are, he's bought a rope, he's bought some tablets, he's bought poison, and how strong is the intent. So very often, sometimes you get people who have an intent but may have no plan. So they feel, I want to end my life, but I'm not sure when and how. So someone with a plan is always more dangerous. Sometimes people have suicidal thoughts where they say that uh, they've thought of a method, but they do not have any uh, plan or intent. So they said, probably I thought I'll jump, or probably I thought I'll have an overdose, or probably I'll do this. But this is the thing. There are also people who have passing suicidal thoughts, which we refer to as passive thoughts. They have no intent, no plan, but just a passing thought that if I kill myself, things will be better. If I'm not here, things will be better. And there are a lot of people who have thoughts of morbidity, that I wish I was dead, I wish I didn't wake up, and some random intrusive thoughts. Now, if you look at this, right from random intrusive thoughts to thoughts of morbidity to a suicidal thought with no intent and plan, suicidal thoughts with a method but no plan and intent, intent but no plan, plan and intent, and suicide attempt happening. All these are not always clear cut. They could always skip a few levels. You could move from suicidal thought to an attempt directly. You could move from no intent and plan to an attempt directly. Doesn't mean that you have to pass through all these stages, but the levels of suicidality expressed here are valid. It, of course, does not indicate the intensity of pain or distress that the individual would feel. It's very important to understand this. Just because I have passive suicidal thoughts, it does not mean I have no intent, I have no plan. So it does not mean that my suicidal thoughts are of less intensity. It does not mean that my pain is not valid. It does not mean my distress is not valid. So one has to be aware of this also. This is another important point that you should know when you assess uh, a patients with suicidality. That is, what is the most common, the 10 commonalities of suicide, which was given by Schneidman. He was a very famous suicide researcher. The common stimulus is unendurable psychological pain, that is psychic. When I cannot tolerate the psychological pain anymore, it's supposed to be what is referred to as unendurable psychological pain. Uh, the common stressor why suicide happens is because of frustrated psychological needs. There are needs which are not fulfilled. There are needs which are not probably met, and those frustrated psychological needs. So, like a failed love affair, a failed promotion, a failure in an exam, very often leads to these things. The common purpose of suicide is to seek a solution. If I'm not here, things will be better. If I'm not here, everything will be fine. If I'm not here, things will work in a better way. To seek a solution. The common goal of suicide is the cessation of consciousness. I do not want to be here at all. If I'm not here, things will definitely be better. So cessation of consciousness is one thing which is there. The common emotion in suicide is hopelessness and helplessness. So this is something that we have always uh, spoken about, that you have to assess patients with regard to hopelessness, with regard to helplessness, with regard to how they feel, and what's negative and positive. Anybody who says I feel hopeless, anybody who says I feel helpless, anybody who says I feel worthless is someone who needs help. The common internal attitude in suicide is one of ambivalence. I'm always unsure whether um, I should do it, I shouldn't do it. In what way should I, move? So that's the thing. The common cognitive state in suicide is constriction. What do I mean by constriction? I cannot think beyond that. That's the only solution, I think. So that's what they say. The common interpersonal act in suicide is communication of intention. A lot of people communicate directly or indirectly in many ways. So they may tend to tell you, I wish I was dead, kahin dur chala jata hu, it's wish that I run away. So multiple ways in which intent may be communicated. And the common action in suicide is aggression, that is to escape. And lastly, the common consistency in suicide is with lifelong coping patterns. So we see a lot of people with repeated suicide attempts also. We see a lot of people that tend to look at suicide as a method to deal with their problems. So how do we assess risk factors for suicide? One is physical disability or illness. It's very important, particularly somebody who's been active, somebody who's been very physically fine. So physical disability or illness is a risk factor. Losing a friend or a family member to suicide, if someone has witnessed that and you have a suicide model already in the family, then your risk for attempting becomes higher. Any exposure to bullying, any exposure to any kind of uh, behavior which involves bullying is a risk factor. Mental health condition is particularly a risk factor. We definitely see it higher in patients with depression, schizophrenia, borderline personality disorder, bipolar disorder. The recent death of a family member, we already discussed. Many people with relationship problems, marital problems, personal problems, peer issues, failed love affairs, breakups are more prone to suicide. Access to harmful means. So suicide rates are a little higher in doctors, they're higher in chemists, they're higher in people who have access to firearms. So access to harmful means is very important. Any patient with a previous suicide attempt is always at a higher risk for suicide. So one suicide attempt, the chances that he will attempt again is always higher. There's also a history of substance abuse which counts. So particularly if I drink, if I smoke, the chances, if I take other drugs, the chances that I may attempt under the influence of those drugs or due to depression caused by those drugs are higher. So these are all the things that you would assess clinically and in your history. Now, how do I know what are the warning signs for suicide? So anybody who feels hopeless, we already discussed this. Anyone who feels there's no hope for the future, anybody who feels isolated or feeling alone is also, that's a warning sign that suicide may occur. Anybody who's aggressive and irritable is more likely to attempt suicide. Anyone who possesses lethal means, so if they have a knife, they have a gun, they have poison, anybody with lethal means is more likely to do it. Anybody who's feeling that they are a burden to others is more likely to also engage in suicide. Drastic mood swings is a risk, is a warning sign. people who frequently talk about death, what will happen after death, where you will go, people who engage in risky behaviors, that is driving rash, over drinking, over smoking, trying to end their life unnaturally, anybody with self injury. So, whenever you have a patient with self injurious behavior or non suicidal self injury, the risk that they would attempt suicide is always higher. People who give away things which matter to them. So, you give away your favorite book, you give away your clothes, you give away things, it's a warning sign. Anybody who's making funeral arrangements, it's a warning sign. Substance abuse, we already said. Someone who keeps talking about suicide, I'll end my life, so it's always a myth that those who talk about it are never going to do it. So it's very important that we take every suicidal threat positively. And a negative view of the self is something which is also a risk for one. It's a warning sign for suicide. Now, if you look at the classical concept, which is the DSM concept of suicide, we have suicidal behaviors which is associated with mental disorders. But there are two specific suicide syndromes that you should know about, which is not DSM, but it's known as the acute suicidal affective disturbance, ASAD, and the suicidal crisis syndrome, SCS. These are two important syndromes with regard to suicide. So, what are they? In ASAD, there is a drastic increase in suicidal intent over a course of hours or days. There's marked social alienation, social withdrawal, self alienation, self hatred, perception that one's suicidality, social alienation are unchangeable, so they are hopeless. There may be agitation, insomnia, nightmare. So that's the acute suicidal affective disturbance. The suicidal crisis syndrome is one where there is a recurrent feeling of entrapment and urgency to escape. Death may appear to be the only escape. You may not always have suicidal ideation. There are affective disturbances, cognitive disturbances, disturbances in arousal and social withdrawal, all that go into the gamut. So the key question that comes up when we assess, do we assess suicide as a symptom? Is it an epiphenomenon of depression, schizophrenia, or a psychiatric disorder? Or is it a syndrome? It's a syndrome that exists along with psychiatric problems, where past suicidal behavior predicts future suicide risk better than a psychiatric disorder. So whether it's a syndrome or a symptom is what is important. Now, this is something just to tell you that how so many factors matter in the biology and causation of suicidal behavior. So you have genetic factors and epigenetic factors that matter. A lot of childhood adversities, traumatic events, substance use, social isolation, stressors later in adulthood, these all act on the HPA axis and they cause a decrease in 5-HT and also an increase in norepinephrine. Anxiety increases. There may be hopelessness. There may be pessimism. There may be impulsivity and aggression, cognitive rigidity, and as a result of which their problem solving skills are not there. The presence of factors like optimism, resilience, humor matter. And all this conglomeratively, there's a biopsychosocial phenomena that leads to suicidal behavior. How do we assess suicide? There are multiple scales which are used. There's something known as a sad person score. So the sad person score is male gender, age between 19 to 45, depression, previous attempts, alcohol use, rational thinking being lost, separated, divorced, or widowed, a serious attempt in the past, no social support, and stating future intent. All this indicates that the risk is high. There is also something known as ispat warm, which are imminent warning signs: hopelessness, anger, recklessness, mood changes, purposelessness, suicidal ideation, as you can see the Now, it's very, very important that we understand that when we look at a patient with suicide, we assess risk. Apart from that, we look at the presence of behavioral traits like anxiety, impulsivity, hopelessness. We look at the presence of an illness like major depression, substance use, schizophrenia, etc. And there are universal interventions. So you have to restrict access to any means that would prevent suicide. Media reporting, yes. Suicide awareness campaigns, yes. Medical treatment, yes. Psychological treatment, yes. Crisis helplines, yes. Now, this is something which I think we do in general, which is important. But how do we assess risk and protective factors? At an individual level, we've already gone through this. I'm just going to run through it. Prior suicide attempts, a psychiatric disorder, trauma, hopelessness, self-harm, family history, personality traits. At a social level, job loss, relationship conflict, relationship loss, war, conflict, acculturation and stress and socioeconomic disadvantage leads to this. What are the protective factors? There are problem solving skills that one has, optimism, self control, one maintains good family relationships, good partnerships. Religion is a protective factor, spirituality is a protective factor, employment is a protective factor, exercise is also a protective factor. Now, normally when patients do come to you, you might conduct assessments. So this is just an algorithm which you can follow. But if you follow all that we have described so far, it's more than enough. Now, if you look at this on the social context, basically environmental and social factors have to go together. So location of the person varies. So certain states have a higher rate. Economic turmoil, yes. Socio-cultural norms. The accessibility of mental health services, I think, is a very, very important factor in preventing suicide. So we have multiple factors like genes, family history, adversity that affects in turn developmental factors. So personality traits, cognitive deficits, uh, chronic substance use, all these come together and increase your vulnerability to stress. When that happens, life events intertwines with psychopathology. There are biological, psychological, genetic factors that play a role. One might engage in different coping mechanisms. There may be mood disturbances and hopelessness, which could lead to thoughts about death. There could be an acts of self-harm and an intent to die, and behavioral disturbances. So that is something which works together. How do I ask about suicide intent? Are you currently thinking about or have thought about death or harming yourself? Have you thought how you would harm yourself? What's your plan? Do you have access to the method? What has kept you from acting on these thoughts? So you come to know protective factors. Do you have any intention of following through the thoughts of self harm? So you know how strong the intent is. What are your plans for the future? Have you or a family member attempted suicide in the past? Um, are you currently using alcohol and drugs? Do you have friends and family with whom you're close? And have you told them about this? And do you tend to be impulsive? These are good questions that you could ask to assess intent. Similarly, again, here, this is a similar table. But what's very important here is, have there been changes in his social life, family, and employment? Is what you can ask as well. There's a Columbia suicide severity rating scale, which post attempt one can use to assess the severity of the suicide attempt. There are a lot of assessment tools, even for assessment. The geriatric depression subscale for suicidal ideation can be used to assess. You have a scale for depression and dementia that you can assess to just look at late life suicide. Always remember, suicide occurs in two groups: the young adult group and the older adult group. Geriatric suicide is always a neglected suicidal facet in our country and all over the world. So if you look at factors that lead and protect against suicide, so there are societal factors, community factors, there are risk factors in the form of relationships and individual. These slides will be shared with you, so you could go through them at your ease, and we could, probably uh, you could get back to me if you have any queries, but it's rather straightforward. Before I end, I only want to say one thing, that it's very important as mental health professionals that we ponder over one thought. We've all been doing suicide prevention programs. We've all been creating awareness about suicide. Whatever we've done in the last 100 years, suicide rates haven't dropped. That means something is going wrong somewhere. We need to think of new ways, better ways to prevent suicide. Thank you very much.
Thank you, Dr. Avinash, for a very comprehensive and in-depth coverage of a very relevant and important topic, suicide. We have one question from one of our listeners. To prevent suicide in educational settings, what support group activities would you suggest? It's in alignment with what you actually ended your lecture with.
Yeah. So I think one of the things is that students in educational settings need to be spoken to about mental health in general. That's the first thing. Secondly, we need to create awareness about depression, anxiety, any disorder. The students need to be told that help is available. They need to be drilled into them that suicide is not an option. And when we find there are vulnerable groups like students who have failed in an exam, students who are probably lonely because they've come from another city here to study, students who have had a failed love affair, put them in groups and talk to them in group sessions, and they will provide strength and resilience to each other. And apart from that, we tell every professor has to take the responsibility. See, suicide prevention starts with everybody. It is everybody's business. So the professor, the college, the management, the faculty, they all have to be available, because a student may not always come to a psychiatrist directly. He may go to a teacher, he may go to a professor. Professor shouldn't say it's not my job, it's the counselor's job. So it's everybody has to take this onus, and I think then only we'll be successful.
By the time we have another question on the chat box, I have some three issues as a clinician which I experience. Are we heading for a suicide pandemic, Dr. Avinash?
Well, I won't say that we're heading towards a suicide pandemic, but suicide rates are definitely on the rise, and they're rising slowly every year. Probably, and I think one major factor is many people a do not know where to seek help. Many people know to seek help but are scared. Many people seek help but don't have family support when they seek help. And I think also what happens is there's a lot of stigma about medication treatment. So the negativity towards psychiatric medication is so much that even though they seek help and we may suggest medication, they're not very keen to take medication. So that again becomes a problem, or they stop it prematurely, or for that matter they don't follow up. So there are multiple factors that cause this increase in suicide rate.
Hmm. Another question is like, why often suicides happen after the patients have seen their treating doctor within a month of their visit?
So I think sometimes it can happen that we put them on medication. Medication leads to a behavioral activation, which is, probably propels them to, go in the direction of ending their lives, which earlier wasn't there. So that is, I think, something which does happen, that they now get into, earlier the thought was there, now they began to plan, because while their depression lifts, they probably experience a behavioral activation phase that can happen. I don't think there's no other explanation that I could think of, unless there are some new stressors that come into their lives.
Okay. We have another question in the chat box from Dr. Kumar. The question is how to manage patient who is coming alone to a private practitioner's OPD, having suicidal thoughts, living in city alone for the purpose of job or studies. It's a real life
So I think,
situation.
yeah. So I think what is very important is when such people come to me, I always ask them to come with a friend or somebody or a faculty who could take responsibility for their sort of treatment. I also take the phone number of the parents and I speak to the parents, and I usually ask for one of the parents to come down. If the person says I don't want my parents to be involved, I'm an adult, then I say you have to have some family member. So then some uncle, some auntie, somebody, or they're staying sometimes here with a relative, we ask someone to get involved. But we need to get someone involved. We cannot just leave them alone.
You did mention about a syndromic approach towards suicide. It struck to me, can a psychiatrist have a phenomenological approach towards this phenomena of suicide? And if so, how to go about it?
Well, I think we've always believed that our clinical acumen and our clinical diagnosis is far more superior to fitting patients into DSM and ICD boxes. So I think definitely we could, look at suicide from a phenomenological perspective. And I think if you even start with a very basic biopsychosocial perspective, and then look at greater phenomenology and look at psychopathology, like one of the questions I always ask my patients who come to me is that why do you want to end your life? Is it because you want to die, or is it because there is a futility in living? And the two are very different. So so phenomenologically the two are, so the people who want to die are more in the impulsive group, the personality disorder group. They're more that, no, I love the pain and I want to die. Whereas there's the other person will say, no, no, you sort out my financial problems, I live, why will I not? It's the futility of living is because things are not okay. So this is something I always ask them. So we assess phenomenologically always. Like I always tell them, he says, I'm in a troubled relationship with my wife. So I said, suppose I talk to your wife and she improves, would you still want to end your life? So he'll say, no, I don't want to end my life then. So we assess phenomenologically that way as well.
Well, that's a very important perspective towards patients. If there are any more questions, you please put in the chat box. Yeah, there is a question mm, from Dr. Rajiv Kurum. So, if patient is suicidal but refuse for admission, how do we manage it?
Well, I think we take it in writing from him. We that he's suicidal, refuses admission. Relatives have been explained consequences of what could happen, and beyond that, what can we do? We can't force someone to get admitted.
So, in such cases, would we start a treatment at a OPD level?
I would, because if they're agreeing for an OPD treatment, why should I deprive them of that? Maybe see, there's so much a stigma about getting admitted. So like, I mean, I'll give you a very simple example. You get somebody who comes and who's suicidal, and they say that in 1 week he has a very important job interview. But the thing is that you give him medication, give him whatever treatment is needed, we will remain with him 24 hours. But if at this stage we hospitalize him, and that goes and they ask for his medical records or whatever, then we'll be in a mess. He'll probably lose the job. Sometimes it can happen that even from a college perspective, there are students who are suicidal, and they very often say, sir, I mean, I'll get admitted after my exams, because right now I just want to finish off my exams and first get this out of the way. And but I tell them, what is the guarantee you won't end your life before that?
Exactly.
So they always say, no, I promise you. We even have tried a no suicide pact, but that is always, of course, very dicey. But I think we explain the risk to parents. But the issue that comes in, I think, in India is that parents always have this case, pehle 12वीं de dene do, then we
Hmm.
will see. Or they'll say कि sir अभी final year engineering चल रहा है, कहाँ आप अभी admit करेंगे तो उसका 6 महीना चला जाएगा. Somehow the emphasis on academic achievement is so much that they don't understand the distress of the person who's suicidal.
It's overvalued here.
Yeah.
Okay, here's another question from Dr. Samtin. How long would you recommend keeping your patient admitted after he says he is no longer suicidal?
Well, I think it would depend on various factors. I mean, like again, I always say, there are a lot of patients who may just deny suicidality to go home. They may say, I'm not suicidal. So it's very difficult. We assess, we look at overall improvement. You can definitely make out in the demeanor of the patient whether he's better. You can make out whether his laughter is his original laughter, or he's just laughing for the sake of laughing. So there are multiple things and ways in which you could assess. So I mean, if he's actually not suicidal and he's doing well, I think maybe a week or two of observation maximum, and then probably send him home, start some therapy which is inpatient first, and then shift that to outpatient. So I think that would work.
Okay. Yeah. Thank you, Dr. Avinash, for answering and taking all those questions. And yes, another one coming up. Some insights about suicidality in children. When is ECT absolutely indicated? Is asking Dr. Kusuma.
Well, Kusuma, sadly, we can't give ECT. The law says we can't give it as per the new MHCA. So there's no point in me saying that, you should give it or should not give it, because the law is very clear. It is not to be given. So we don't have a choice here. We don't have a debate here that it should be given. Earlier, before the law came in, we used to give it in acutely suicidal adolescents and children. But now the MHC is very clear that ECT will not be given to adolescents. I don't know if a mental health review board would allow you and go beyond the law to allow you, but still I think the law says you can't give it. So you'll have to manage. I mean, there have been cases where we've had to wait, somehow cross our fingers, wait 6 months, 8 months for the person to get 18 and then give him ECT. But that's the way things are.
I think we are done with the questions now. Thank you, Dr. Avinash. I'll give it over back to Dr. Rashmin. Hello.
Yes,
Yes.
thank you. As expected, fantastic. And I think Avinash's USP is how he's able to simplify a complex and myriad topic and try to make it so easily relatable. So absolutely fascinating. Thank you very much, Avinash. You outdo yourself every time. And of course, Dr. Deshpande has very ably maneuvered the entire session to make it more interactive and more interesting. So thank you very much once again. There are a few controversies regarding suicide and a lot of misunderstandings, but I'm glad to say that we are making strides in the right direction, and hopefully we are understanding it a little better. It hasn't brought down the suicide rates, unfortunately, they're still going up, but we are beginning to understand the pathophysiology and the mechanisms of suicide a wee bit better. The law is not entirely favorable in many matters. Fortunately, suicide is now decriminalized in our country, so that's a big step in the right direction. And so people are willing to come out more in the open and talk about suicide as opposed to earlier, where it was always hushed up and brushed under the carpet because they would fear the law more than they would fear their illness. So it was very unfortunate, and now we have made a stride in the right direction. With regards to the probability of using ECTs in children, like Avinash says, for the moment the law prohibits it. But I think there is a caveat where if there is very poor response to any conventional treatment, then the treating psychiatrist can apply to the mental health review board and they can make an exception and give ECTs if it were to be clearly established by 2 or 3 separate psychiatrists that is perhaps a life-saving measure. But that's an exception rather than the rule. The rule still says that ECT should be avoided at all costs in children and in adolescent age group until the age of 18. I do not know what is the scientific grounds for that claim, but then rules may not always be connected to scientific reality. Nonetheless, that's where we are, and it was definitely a very, very enlightening talk, and we are glad that we had Avinash and Prasad to be with us on this day and help us understand this complex topic better. And I assure you, we'll try and bring you more interesting topics going forward. And I thank all of you for making the time and being a part of this program as well. And of course, thank you to Sun Pharma for their unflinching support. So thank you all once again. And until the next time, I wish you all a good evening. And once again, thank you, Avinash. Thank you, Prasad.
Thank you.
Have a great day, everybody.
Thank you.